Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound.
Joining us online. Just to remind members, committee meeting will be recorded and broadcast through Parliament buildings and online. And for those in the public gallery, just you can use mobile devices as long as they're in airplane mode and muted. And no one is permitted to take photographs or record any of the meeting. I have a number of items under Chairperson's business, which you'll not be surprised. I suppose the first item is in relation to the emerging news on the Royal Maternity Hospital, following the debate on Tuesday, when the Minister outlined a further issue in relation to the hospital. I'd asked the clerk to contact Belfast Trust to request an urgent briefing on this issue, and members will be aware this has been scheduled for next Thursday, the 5th of December. And in attendance will be the Belfast Trust Interim Chief Executive, the Chair of the Trust Board and the Director of Estates, and a representative from the Department of Health will also attend. I'd also suggested that I think it might be worth that the committee does a visit to the site, because there are a number of facilities that we need to get an understanding of the scale of this problem. So with the committee's agreement, I was going to request that we could maybe do that in the new year, because we've seen lots of issues like this arising on various projects, and I think it's incumbent on us to make sure that we're doing everything we can to ensure that these situations don't arise again, and that we at least have a very clear understanding of what is happening, why, and what this will now mean moving forward. So if members are happy, we can put that request in and try and get that organised as quickly as possible. So there's a in light of the trust coming to the committee next week, some of the briefings then will be moved to after the following week. Sorry. So Colin, sorry, do you want to come in there?
Thank you, Chair. Look, totally agree with the idea about going and doing a visit. I think that would be important to give a good understanding of it. I'm just wondering though, could we maybe schedule it in such a way that we have some information or some idea from the department as to what all of the issues are and what their remedies are, so that we can set what they're telling us against what we actually see on the ground? Because I'd just be afraid that if we don't have all the knowledge of what's happened, when it's going to be sorted out, when it's going to be addressed, and what the timescales are. I'm not sure what other committee members are like, but I'm certainly no building expert. I'll simply be looking at walls with holes on it, not really understanding what it is that needs to be done. But I would want to know that before we actually go, so that we're not sort of blindsided with technology and announcements on the day.
No, absolutely. And I would like to think that when we have the various officials in front of us next week, we will get a good sense of that. Like yourself, and I'd actually raised this in an earlier discussion ahead of today's meeting, I'm not very technical, so I do need a good understanding of what's happening, and as I suppose an MLA from outside of the constituency, to understand kind of that bigger project, what it includes, and that scale of what we have learned this week. So Diane, did you want to come in on that?
No, I absolutely agree. I think that's a good idea. Although I do think that the Trust have now had a considerable period of time in which to assess these issues. And I would like to think that the Trust are coming to us with a full list of issues plus some solutions next week. I wouldn't like us to actually get to the stage where we're still talking about maybe, might, or whatever. I do think it is very worrying that a Minister for Health stands up in the Assembly and says, I've just learnt of a new issue this morning, in advance of a debate that they've known about for quite some weeks. And I think that there must be issues around the accountability and transparency of that, because I assume the Minister is doing his own investigation into that, but we do need to know which officials knew, why was the Minister not told, what did the Trust know, etc. And I think that that's really important. So I'd like to not just get a scope out of the issues, but I'd like to get some of the solutions.
Yeah, no, absolutely. And I suppose just on that point as well, Diane, I mean, we had chief executives of the trusts in here last week.
Yes, yes.
We also had a dedicated session on the maternity hospital less than 8 weeks ago.
Yes.
And this, I mean, I would like to get clarity around when this issue first became apparent. But the fact that that less than a week later, the Minister's learning of it, and it wasn't mentioned, I think, is quite concerning. So we need to understand why that happened. So I agree with your point on that. Nuala?
I'm content as well with everything, and agree with regards to a visit to the maternity site, and maybe the clerk can advise if the committee can actually bring themselves an external advisor on issues who is not related to the department or trust. I don't know if it is appropriate, and that's why I'm asking. It's just given none of us are from a structural engineering background, but also there is issues now with the more medical side of it too. What if it's not appropriate? I'm happy to leave that, but I know that what will happen is that I will go back and I will run it past people within the sector.
10 more questions in your head.
So
yes.
I don't know how we might do it as a collective.
Just say, Chair, from the committee's point of view and procedural point of view, there's nothing to stop the committee doing that. The issue would be is finding the appropriate person, and we probably need to go through a procurement process, which may take a bit of time. If members knew somebody that may be willing to help out or would have that knowledge, I'd be happy to have a conversation with them.
I suppose, Chair, on that, I mean, I don't disagree. I mean, you know, I'm not a microbiologist. I don't know about water systems, and I don't know about structural issues. And I suppose if we were to get someone, that same person would have to have access to all of the information that the Trust has. So it may be something that we keep in the background and think about, you know.
Okay, but I suppose in the here and now, I would like to think that all the information that we need will be presented to us when they come to us next week.
Absolutely.
So that gives us the opportunity then, when we go and see on site what exactly we're talking about. I think for me, it's about that visual. So as someone relatively new to the health committee and issues outside of my own constituency, for a capital project that's been on track, has been in the system for as long as it has, to understand what that looks like, what's involved. Are there other something that's jumped out at me is, are there other facilities that are on in that capital are waiting to be built that have potentially got these issues, could have these issues as well?
We do know that the acute mental health facility on the Belfast City Hospital site, because I've asked questions about this now, has significant problems with the water supply. We know that the new main hospital on the Royal site, when it opened, had huge issues around this, and all of this takes time in terms of the reparative work, but it also takes huge amounts of money. And in a health budget that is actually very limited in money, particularly that capital budget where very little additional money is coming to that budget, we are eating this up on avoidable issues. And I think that it is about the transparency with public money, it's about accountability for public money, and it's about ensuring that we know that when a project starts, that we can complete on time and within budget.
No, absolutely.
We haven't been able to do a lot of that.
Okay, member. So, well, as I said, we'll probably the next week's session will be it's a single item agenda in relation to this. So, we will hopefully get a good detailed look at that. So thank you. Members, just to speak to the informal session that we had on Tuesday afternoon with departmental officials in relating to the general medical services issues and primary care. I certainly found that a very informative session, so grateful to Garode and Margaret and Aaron who came along just to talk around some of the things around MDTs and some of those issues, and they are happy to do that further where required. That's the last of the meetings of those kind of those type of informal sessions, and we look again at this in January at our next planning meeting to see, you know, going forward what other approach we could take. And just as well, I'm aware, and I wasn't able to attend, unfortunately, the Foundations for Future conference was held yesterday in the Crown Plaza. No, yes, yeah. Regarding the independent review of children's social care services. And Professor Jones was in attendance, and I know Nuala, you chaired a panel, a Q&A panel as well with members of the Children's Services Strategic Reform Board. So.
Yes, Chair, if you don't mind, I want to say that stakeholders, and Ray Jones as well in particular, was grateful for the emphasis that the committee has actually been putting on the Children's Services Review. There was one takeaway from it for political representatives that Ray did express, and that was the joined up approach from committee to executive with regards to supporting the idea in particular of an ALB, and also pursuing the actual recommendations to ensure that every party is on board. I committed to bringing that back to committee so that people can use their influence with their executive colleagues to support that.
Thank you, Nuala. The only other thing I did want to raise, because I was hoping to get an action out of it as well, on Tuesday, I and other members will have attended the cancer focus event on lung screening and routine lung screening for lung cancer. Yeah. And I think it would be maybe a good idea to write to the Minister to see what consideration his department has given to introducing routine lung screening, because I think it is screened earlier in other jurisdictions, and I suppose lung cancer unfortunately is one of those cancers that by the time the symptoms are people recognise the symptoms, it can often be too late. So it would be good to get an understanding of that, Linda. Mute. Oh, that's you.
Sorry, yeah, just whenever we're online, we just need to be unmuted. We can't unmute ourselves, so sorry about that. Can you hear me okay?
Yeah,
Sure?
yeah.
Yeah, sorry about that. Yeah, I think that we should also ask the Minister for detail of if it's not something that is under active consideration, or that he hasn't plans to actually implement, what work has been done, what scoping work has been done in terms of costing, and then in terms of the cost savings, you know, if we actually are able to diagnose people at an earlier stage. Because thankfully, even though people, whenever it is diagnosed, it can very often be at a later stage. A lot of people actually have significant, good outcomes in terms of getting a longer term of life. But that there's a lot of cost in treatment, and there's a lot of cost to the individual themselves in terms of just their own life and all of that. So, but there is a lot of cost to the health service as well. So I'd like them to work out if they were able to detect it sooner, and through screening, the savings as well. Because I find that in all of these issues, we're always looking at the cost, and we're never looking at how much could be saved if we're able to. The other issue is very often this is not being diagnosed at all because people recognise symptoms. It's been diagnosed because of scans for other things. So it's when they come into A&E or into the health service with symptoms for something else, and it's diagnosed accidentally with scans for other issues. So and almost all the people who I know who've been diagnosed with lung cancer were not being examined for lung cancer.
Yeah, no, absolutely. I think that would be good, because certainly from speaking to some of the organisations on Tuesday, that was the key focus as well, is that there would be savings actually, because people would, if they're seen earlier and it's detected earlier, then the level of care required is often less. So I think if we can get that as well, that would be great. Thank you, Linda. Okay, members, item number 3 then, in the draft minutes from the meeting held on the 21st of November, page 6 of your pack. Are members happy enough with the minutes as drafted? And I have no matters arising. So I'm just going to move quickly to the item number 9, which is the independent neurology inquiry retention and disposal schedule. And if I could refer you to the papers in tab 9 of the pack, including the clerk's memo at page 243, and the retention and disposal schedule, which was laid on the 15th of November at page 244. If members have any comments in relation to that? No? Members content with the schedule then as set out? Yep. Okay, thank you. Okay, members then, so we'll move back to our original agenda item, and that is number 5, which is the oral briefing on health and social care workforce policy from the Department of Health. And I could refer you to papers at tab 5, page 17, which includes a written briefing from the department, which provides a high-level update on workforce policy issues currently being progressed, and a response is also available in table papers at page 2 regarding the department providing figures on actual vacancies which the committee had requested. You're all very welcome. Thank you. In attendance today we have Phil Rogers, Director of Workforce Policy, Peter Barber, Head of Workforce Development Unit, Stephen Galway, Head of Workforce Policy Development Business Support Unit, Rodney Redmond, Head of Workforce Strategy, and Chris Wilkinson, Head of Pay and Employment Unit. So thank you for your attendance today. We have about an hour for this session, and it will be covered by Hansard. So if we can invite you to make your opening remarks, then I'll open up for questions.
Okay, thank you, Chair, and good afternoon, everyone. I wasn't proposing to have a detailed opening statement. I think we've provided a paper, maybe just highlight a few, I suppose, developments and successes over the last 6 months since we were last up with you back in May. I suppose one thing to highlight, we're continuing to make good progress in terms of delivering actions in our workforce strategy action plan, and we've also begun the process of refreshing that and developing a new action plan for the 25, 26 to 27, 28 period. We're seeing continued growth in the HSE workforce, 16.4% growth between March 18 and September 24, which are the latest figures, which were just published a week or two ago. And that's across all of the key professional groups. So we've seen in that period a 24% increase in medical dental workforce, nearly 17% increase in nursing and midwifery workforce, and a 22% increase approximately in the professional technical workforce, which includes our AHPs. Despite the financial challenges which we're facing in terms of the DOH budget, we did manage to grow the number of commission places in our undergraduate programmes for August, September just past. Obviously we have ambitions and a need identified to grow those further in the coming years. And we also managed to grow our general internal medicine and medical specialty training programme through NIMDA. We're making some reasonable progress in terms of agency spending. When we look at the base year of 22-23, which is probably the high point of agency spend, we've seen a £17 million reduction in spending over the year to 23-24, and that includes a reduction in £90 million in terms of the off-contract spending. Our current projections for this financial year, so in the 24-25 financial year, is we're estimating, from where we are at the minute, we're estimating that we'll see a £39 million reduction compared to the 22-23 baseline in nursing and midwifery spend, with another £5 million nereduction in healthcare assistant spend and £13 million reduction in social worker spend. So in those three sort of professions, that's the guts of nearly 60 million reduction in spend projected for this year. Obviously, a lot can happen between now and the end of the financial year. I suppose the other thing just to highlight is obviously in terms of where we are in terms of pay at the minute. We're making some reasonable progress in some of the outstanding get my numbers right, my 23-24 pay award. So the ongoing dispute with resident doctors and SAS doctors, and we're making some good progress on that. Had met with the resident doctors yesterday. Can't say too much about the detail. We've agreed that we wouldn't say too much publicly, but we're making some good progress there in that space. In terms of the 24-25 pay award, obviously aware again of the financial challenges that we're facing, and there's currently a gap identified between what we need to maintain pay parity and implement the full 24-25 recommendations of the various pay review bodies. But again, we're engaging with the unions and making some progress there. And again, if it's okay, we've sort of want to keep those discussions pretty tight at the minute. We're sort of working away with them in the background. So,
okay, no, thank you for that, Phil, and thank you for the papers. I mean, there is quite a lot of detail in them as well, so it's good to get the opportunity to speak to that. I suppose just on the pay negotiation, I'm not going to ask you for any specific detail. I saw the SAS doctors have recommended the pay award that has been proposed, so that is hopefully good progress. So I suppose really my question is, and it might be a stupid question, but given that we have a figure for the amount required to achieve pay parity for 24-25, but we're negotiating for 23-24. If an agreement is reached on the amount on the table, or the proposal on the table, will that impact what's required then for 24-25?
No, it shouldn't do. I think the SAS, the deal or the agreement that we've got with the SAS doctors that they're now putting to their membership, that money is
okay.
We've got that.
Yeah.
I suppose that technically, if they accept it, yes, there will be a very, very small, because you're applying whatever the recommendation is for 24-25 to a higher
and that's kind of what my question is.
It'll be a marginal amount of number.
And likewise then with the resident doctors.
And likewise with the resident doctors, there will be an implication, but it's marginal in the grand scheme of the gap that we currently have.
And I suppose the only reason I'm asking that is because obviously that shortfall is still there. I mean, I think there's a whole executive approach to try and address that to achieve pay parity. So I thought hopefully that's not going to be another.
I think it's fair to say that we have, in our estimate of what the gap is, we have included an assumption that those two, both the SAS and resident doctors, that the implications of those will be included in that in our estimate of what the gap currently is. Okay.
So that brings me on to my next question in relation to agency spend, and a note in the briefing. There's been marginal reduction, on year from 22-23 to 23-24. But I suppose one of the biggest concerns I have is in relation to the off-framework spend. I think 22-23 was 196 million. And I know that it says in 23-24 that was down to 106 million, 90 million reduction. At the minute then for 24-25, because I suppose for me we see a 2.3% decrease in the nursing and midwifery workforce. I know it's from 2018 to now. So some of the issues that I can only imagine would be some of the disparities in pay and issues around pay and things like that, which could be a reason for people leaving the workforce, given the significant pressure. And we've heard, we've met with RCN, the Royal College of Midwives and others, and that is coming across very clear, particularly around safe staffing. And now we're obviously trying to achieve pay parity as well. But when you're working for an amount and you have someone working beside you who's maybe being flown over from England at a rate of a very high rate, I'm not going to quote figures because I don't have the exact figures in front of me, but I mean a significant rate for doing the same job that you're doing at a far lower rate. I can only imagine the impact that will have on people morally. So I suppose my question is, I understand that in emergency situations there's probably no choice, and if we can't get staff to deliver safe service, we have to look at all options available. But I would like to think there's a concerted effort to do it, and I know that the previous minister had brought in policy to try and tackle that. For 24-25, have we any sense of what a further reduction may look like in terms of that off-framework spend?
Certainly, in terms of nursing and midwifery, I think there will be no off-contract spend in 24-25. There may be a couple of small areas where there will be some prisons, because it's particularly difficult to recruit to prisons, and I think Muckamore, Stephen there, and Muckamore. So there's very, but the previous minister before the last suspension of the Assembly and Executive, his challenge to the HSE was to completely remove off-contract agency spending, and we've done that. The new contracts are in place. We're actually seeing, or reported to us from trusts, that a number of organisations who previously would have provided staff through off-contract are actually contacting them to see how can we get onto the contracted framework. And the answer is sorry. At the minute, you can't. There's no room. We've identified our 20 people. So in terms of nursing and midwifery, there will be a very, very, very small amount of off-contract spending, and that's just in those really difficult areas.
Yeah. Okay. And hopefully, maybe by the time you guys are next in, we'll have a better sense of what that has looked like for this financial year. Because even in terms of how the rates of pay are agreed for those for off contract, it beggars belief. It really does. From my perspective, there might be a very good reason for it, but I just think if we really want to drive people out of our workforce, we're doing the right thing.
Yeah. And I think really now, what we're looking at now and going forward, and actually Stephen and I will be at a meeting that the trusts are leading tomorrow on medical locum spend. I think that's the next big area we've got to focus on. I think we've got the new contracts in place in terms of agency nursing and midwifery. We're taking a number of further actions to support and drive down the spending in that area, and that's all working reasonably well. But the next focus then is to look at medical locum spend, and some of those things that you're talking about, like eye-watering amounts of money being paid to individual medics, is there's some very big numbers there, and it's quite.
Well, what Jim said to me, if you're talking of 196 million on off framework, I know it's in the previous 22-23 financial year. And we're sitting here saying about how we need 100 million to achieve pay parity to stabilise our workforce and look after our permanent staff who are doing it for a far less rate, then that's where our focus needs to be. And I think if we can get that right, then we can, because this, even though it's non-recurrent, it is essentially recurrent money funding, because it's needed every year on year, albeit it's reducing gradually. So, and I suppose the other thing I would say is that from speaking to staff working in various elements of our health and social care system, where maybe we're bank staff, things like that, who are doing bank shifts at the same rate of pay as they do for their ordinary shift. To me, that's a disincentive to come in and do overtime or help out where it's needed. So I think that's something we do need to look at, if possible, because I would rather see that where we have gaps in a team at any time, that it's our own staff in-house we're able to do that, and people will be more willing to do if they're valued properly.
And I think, Chair, that reflects the the new protocols that are now in place across. So same protocols in place across all of HSE. That it's a stepped approach before we are taking a decision to employ agency. So the first thing you do is you look at your own team, you look at overtime, you look at bank staff, and eventually you'll get to on-contract agency. And obviously, because they're contracted, the margins are much. There's still a bit of a additional spend, I suppose, associated with the agency framework at the minute, but it's not at the sort of levels that it would have been in the past with off-contract spending, which were really.
I know, and I do know that there is that stepped approach. As I said, it's probably its last resort. But I suppose the point I'm making is that in-house staff are probably more likely to do it if they feel that there's even a slight incentive, and that could help to offset. I mean, it's only a suggestion. Maybe in practice that won't work, but I do think it's something we should consider, because I have seen in my own area recently where they've introduced an enhanced shift pay to try and stabilise maternity services, and that has been something that has helped to try and get cover. So I suppose that's that one. My last one, I suppose, just because I know others will have plenty of questions on this. This morning I attended the seminar, the policy forum it was an online seminar in relation to our health service, and one of the things that came across really strongly was the need for workforce stabilisation if we want to protect our health service and secure it. And I suppose one of the cornerstones of that is our GPs. And given that over 20% of our GP workforce are over 55 years old, and the most recent report by the Royal College of GPs noted that many of them are considering early retirement given the huge pressure they're under. Are we looking at specific retention measures in relation to GPs? Because I think where those services collapse further than what they're already at, we're in really dire straits, because that means people are going into secondary care way before they need to, or aren't being seen and are ending up with far worse outcomes. So it's just to get an understanding of that. And I know obviously there's various elements of negotiation around GP indemnity and all of that is part of this, but I think retention is crucial.
So I've got to slightly pass the buck on this. It's in terms of obviously GPs, they're not part of HSE per se. Yeah. They're obviously independent contractors. So we have in workforce policy or remit there is not quite as direct as it would be in other areas. We have made some moves, and Peter maybe have some numbers in terms of increasing the number of training places on the GP programme, obviously to try and build that workforce for the future. And through workforce strategy, we have plans to work with chief professional officers. So looking ahead to the next action plan for a range of retention plans, because there are challenges in all the professions in terms of retention. So certainly, I think a retention plan for the GP workforce would be something, and it's probably not just GPs per se, as the GP workforce, the primary care workforce. Looking at multidisciplinary teams and the different professional groupings that are working across primary care. So I think again, through our workforce strategy, we have these intentions to put in place retention plans for a range of different professional groupings. So that would include GPs. And
is that in engagement with GPs themselves to understand what are the issues that are driving GPs out of the service? Yeah, so it will very much be driven by our chief professional officers. So we'll be looking to our medical officers to drive that forward with us. But yes, we'll be working across key stakeholders. We completed one recently. There's an ongoing piece of work in relation to nursing that was done, and again, that's looking. It's across the professions. It's engaging the Royal Colleges. It's engaging all the appropriate stakeholders to develop a retention plan for a particular professional group. So I say we'll be looking at that going forward in relation to the next iteration of our workforce strategy. Peter, did you want to comment?
As Phil was saying, our focus is on encouraging workforce supply. So in terms of, we recognise the importance of general practice, both now and going forward in terms of the future delivery of services and how they'll be constructed. So we're looking at growing the numbers coming through from medical school into our GP training programme. So two initiatives over the last couple of years. One has been working with the Queen's as they have reoriented their programme, the medical programme. So 25% of the time will be placed of clinical experience will actually be in general practice. And it's been great as well how the GPs have embraced that, even notwithstanding all the other pressure that they're under, to step up to support that. It's a massive change because Queen's was about 6-7% before that, so it's gone up to 25%. And then the new programme at McGee also has a very high level, about a similar level of exposure. So that's really the evidence is when people find a good experience in their training and their education, that's where they can be more likely to choose as their long-term careers. So and there's clear evidence behind that. The other side of the career we're involved in would be the commissioning of the general practice training programme provided through the Deanery in Northern Ireland. So 2015-16 we had 65 people per year going through that. This year, current year, we've recruited 121, and that's the level, the commissioning level. So we're trying at a number of levels to work through generating the supply. Clearly, though, Chair, as you pointed out, this is a complex issue, and you're also talking about the retention bit.
Absolutely.
But what we're trying to do is to show the vision and raise the opportunities and facilitate that.
No, well, thank you for that. I suppose it's great to see the increase in numbers, but my fear always will be that once we get them, do we keep them? Because if you're particularly a newly qualified GP, for example, and going into a very pressurised situation, you know, we've heard explicitly the real stories of what it's like in GP practices at present. We want to ensure that I mean, it's like social work as well. Newly qualified social workers coming out, going into children's social work teams that are on their knees with really, really complex cases and not being able to do the work that they want to do. And that's driving people out before they even get an opportunity to.
Without that, I don't want to underplay at all the other issues.
Oh no, I know that, but I suppose it's just to make the point.
If I just share one aspect we have discovered with this is that there's so many GPs out there wanting to encourage other people to become GPs. We've found that as well. Very young people coming through, and people like that engagement with medical students and indeed helping the GP programme. And that's why I say, notwithstanding all the other pressures, we've been able to get a system that has facilitated this massive expansion in clinical placements across general practice. And I think that is also a help to some of the GPs as well, that they see, as you probably heard, they'd like to have portfolio careers, and this is a way of enriching their experience and encouraging them to stay in the primary care scenario. I like to think then they can then infuse the new folks coming through, and hopefully that's going to be part of it. Obviously, there's many other features and aspects to it, but that's one of the things on the training and development side we're working with universities on and GPs. On developing.
Okay, thank you, Peter. Thank you, Phil. I have Danny.
Chair. First, I'm just going to declare an interest. I work on the South and Eastern Trust Bank as a Band 5 registered nurse, so just to put that on record. I have a couple of questions just relating to what you were saying about bank and agency spend, but first I want to acknowledge what you were saying about the negotiations about pay parity, and I appreciate you'll not be able to go into it, and you've said there's reasons for that, but I would want to urge that the Minister prioritises these negotiations, because without our staff you don't have a service, and certainly we want to avoid any industrial action that's coming into the winter. So appreciate your answer from that. That was going to be one of my questions anyway, but I appreciate you can't go into that. Just in terms of the spend, the agency and locum spend £400 million, 5% of the entire health budget is agency and local spend, if my maths are correct.
I'll take your word for it. I'm trying to do it quickly in my head, but yes, I'll take your word for it.
No problem. I want to know what's driving that. Why are we spending so much on bank and agency? Is it sickness? Is it staff vacancies? Is it staff leaving the service? What are the main gaps that are requiring agency shifts coming in? What are the main gaps that are requiring locums? And what are we doing to reduce those?
Yeah, so I suppose I would say what's driving that is a combination of some of the factors that you have outlined. Certainly, vacancies. If you have a vacancy, that's a gap in service. You need somebody to do the job. Mm-hmm. So if a post's not filled, you have to try and fill it or fill the shift some way, and some of that might be through agency, but it will also be things like sickness levels as well, and things like that. And we're seeing some progress in terms of sickness levels as well. So I think when we look at it in the round, it's multifaceted as to why people need to engage with agencies to bring in temporary staff, and I think some of the positives that we see in terms of driving down that agency bill is we see more people working in HSE than we ever have before. We see the vacancy rate coming down. We see our sickness levels coming down, and I think that's all then playing into that's for me, that's explaining why we're starting to sort of put a bit of a break in terms of the limits, in terms of the agency spend. In some areas, particularly in some medical specialties, there will be a seller's market out there, and that's what we have seen from our analysis in terms of the medical locum piece. We would rather people were employed by HSE and working in HSE, but in some circumstances that's obviously not the case, and people can effectively, we have seen, ask for whatever price they think they're worth, and if we need to maintain a service, sometimes that has to be paid. So I think that's probably our focus moving forward. So we've made good progress in relation to agency spend on the nursing and midwifery side. We've made good progress in relation to the social work side of things as well. We continue to sort of drive those down, but the focus now is to turning to medical locum spend, and we'll be putting in place a new contract, a new framework for the supply of medical and locums, medical and dental locums into the system, and that should be in place by next year. But like what we did with agency nursing, there's lots of other complementary measures that we need to take to drive the spend down, and that will be about trying to encourage more people into HSC employment. It will be increasing perhaps the number of resident doctors through increasing our number of training programs. It will be increasing supply where we can, if we're able to increase the number of either undergraduate places or looking to international recruitment to increase supply. So all of those measures will be complementary to a new framework, a new procured framework.
Okay, we've seen figures, and we've seen the level of agency and local spend ballooning over the last couple of years. Now, it's only a couple of years ago, I think it was around about 200 million. So, what is a reasonable level of agency spend, and, when do you plan to get there?
It's difficult to say what a reasonable level would be. I think I think we've got to recognise that 22-23 was probably the high point, and it's then that we started to, on the challenge laid down by the previous minister, that the system really started collectively to work to try and drive this down, and we've seen that progress in the last financial year, and as I said, we're seeing further progress then for 24-25, and I expect the number to be well down again this year. What a reasonable number is it's a very difficult question to answer. I don't think we collectively would have an answer for it.
No target?
There's no targets in relation to reducing agency spend.
As a percentage of the budget, for example?
No, that we don't have any we've targets, I suppose, in relation to some of those things which will influence the level of agency spend. So we have targets, for example, in relation to vacancy rates. We've got targets in relation to sickness levels, but we don't have any targets per se in relation to agency spend, other than we want to see it driven down. Well, I suppose there's some targets, for example, we want to eliminate off-contract agency spend, and we've done that. We want to eliminate social work spending, and we've done that. So it's something, to reflect on and think about, but we don't currently have any specific targets identified for reduction in agency spend.
I do find that quite shocking to hear. What you've described, and particularly about the seller's market, it seems there's a perverse incentive not to work for the trust. And, to do locum shifts, you get paid a lot more, And
I think that's our aim is to start to tackle, our aim is to start to tackle that, and try and shift the balance so that it is more attractive. And we've seen we can do it, because we've done it in nursing, where you would have had, as the chair described at the outset, examples of nurses flying in from England off contract, spending, costing a significant amount more than an HSC employed nurse like yourself would have cost, and we've eliminated that now. So that's, so it shows that it can be done. It just takes it takes a lot of will and a lot of determination and a lot of, dare I say, backbone from individual trusts and individual bits of trusts to hold the
When you
line.
talk about the off-contract stuff, and I totally appreciate the off-contract stuff is hyper expensive compared to a normal staff member, a contracted staff member. What you've eliminated with the contract or the off-contract staff, would that be referred to as the low-hanging fruit? Would you be able to make the savings that you're planning to make then are obviously on top of that? If you've already eliminated the low-hanging fruit of the off-contracted staff, where are the rest of these savings?
So the rest of the savings will come from reducing demand for agency staff, which means getting more people working in the HSE. And as I say, we're starting to see the fruits of that in terms of when we look at our workforce stats. All professions are growing. All employment in all trusts is growing. That's whole time equivalents. So we're growing our HSE workforce. More people are working for us than I've ever done before. The other bit is then to eliminate demand through reducing our sickness levels, and again we're seeing good progress being made by trusts in terms of driving down sickness levels, and that will continue to be a focus for trusts going forward. Be more people into training, recognising that that's going to be the workforce of the future. Obviously with medical specialty training, they are delivering service as well as being trained. So it's all of those things that we're doing collectively will hopefully drive up employment in HSE, will drive down demand for agency. So that's one element of it, is to drive down the demand for agency. Another element is the way the contracts are structured, and Stephen might say a bit more here. It allows us on an annual basis to squeeze the margin. So I talked a little bit about the price that we pay to an agency for a shift is more than is the cost of employing someone directly. That margin, the contract allows us to squeeze that every year. That's revisited every year, and the ambition of trusts collectively, and they're the decision makers here, is to squeeze that every year. So the excess bit we should squeeze as well, and that should again reduce.
One last question, if you don't mind. Now, the alternative to agency is bank. What are you doing to incentivise people not to go to agencies but to register with their own bank?
Yeah, so we've got a project specifically on addressing and reforming the bank and looking at a regional system. You say you're a southeastern bank, but I think we're looking more at a regional system of bank. But we've got a specific project as part of the agency reduction working group that's going to drive that forward and drive those reforms in the next. That project will be taken forward over the next number of months.
So look at trying to enhance the process of using the bank in terms of IT infrastructure, how that would work regionally across all the trusts, and how payments would be made on a much faster basis than they probably are at the minute, ensuring that staff are incentivised, as well as maybe looking at the rates of pay if that's a potential option, but looking at the potential for how you can pay your staff quicker and ensure that if someone identifies a shift that they want to work, they're able to get paid for that the following week. Those are the sorts of options they're looking for in terms of the bank reform.
Okay, thank you, Danny. Nuala?
Thank you for your answers. Some of the things that you'd said were kind of interesting. I want to just expand. You mentioned you didn't have a target for reducing the spend, but would or has consideration ever been given to like a needs-based assessment of the staffing infrastructure within HSE? So rather than looking at just vacancies, because the vacancies are what you can't fill, but we know if they were all filled, it probably still wouldn't be enough in terms of what each discipline might need. Like social work, for example, they may be able to fill vacancies, but what we were hearing from social workers is actually what we need more. Has there been that needs-based consideration, analysis of, okay, this is what we need to have a functioning health service that doesn't have the languishing waiting lists, that is stabilised, so that there can be, that in itself would be, a target to raise and meet that need, but also would it inevitably then reduce agency spend? Has that ever been done for different or any discipline?
So there's probably two parts to an answer to that question. I think one is we undertake a programme of workforce reviews on a regular basis. That's a rolling programme across a range of different specialities, across a range of different services and I think we have a in
You've
the papers we have an annex
there of the programme.
Of all of the workforce reviews that we're undertaking. So those workforce reviews will be based on an agreed, I suppose, model pathway of care, if that makes sense, which tells us how many people you need, and then we gross it up to a population level, and that tells us how many people should be working in a particular area, and how many people then, from our perspective, we need to be thinking about training for that organisation. At an operational level, then trusts are doing similar things. They have, for example, in nursing we have delivering care. We don't have it. Our nursing colleagues have delivering care, which basically tells it's a tool to identify a need for a particular service in a particular location, delivering care.
Yeah, they're actually, as we meet,
Yes.
they are looking at a refresh of that programme, and that draws in all the trusts. I mean, it's getting more at the operational level. What Phil and I are talking about here is the strategic overview and supply and the trading numbers, but this is actually down then to the clinical settings.
I think it's important because we have heard it from a number of different bodies in terms of, like, specifically when you look geographically at need as well, in areas where and I use the social work area for example in particular. If certain districts have more caseloads than other districts, they are going to need a bigger workload, but the vacancy level doesn't actually match, if it was filled, what the need is. So you're telling me it sounds like it happens, but on the ground, that's not what we're hearing in terms of what we need.
Our expectation would be that the trusts are doing that workforce planning at an operational level, so they should know broadly what their
Are they doing it at what they
is.
can afford, or?
Be a question for the trust. I would assume what they would have done.
What need, not what you can afford. The department does. It's based on need.
Our responsibility is at a strategic
level. So what we
about
look
ensuring
is,
there's a supply into the system,
and also about that's related to as well transformation. What is the optimal way of delivering services across the region for all of our population, and as you say, addressing issues like inequalities, which a minister is particularly keen to address. But we deal at all that sort of level and looking at what is the optimal skills mix, because that's changing as well, and things like that. But so it's a complex issue, but it is this interface between the strategic bit and then the operational day-to-day reality on the ground.
And I think that is interesting, though, that it's an area maybe worth exploring a bit further with the trust, because I know it's not as simple as this and it is complex, but it's almost like, what's the point of doing the strategic thinking if, like,
but we have to then absolutely align it to the service delivery model. What do they need, and that should be absolutely driven by meeting population needs, and they are assessed across the region. But in a sense, the department, we don't allocate people. We are providing the workforce supply, and the whole emphasis on the workforce strategy is to provide those tools.
But it just comes back to, again, is what we're hearing is it's not like the service model where it's not meeting the need. So at some point, there's a bit of disjointedness there, but it's something that we can maybe pick up on again with trusts. And then my last question, just around, you had mentioned, Phil, the new contract for medical and dental locums, and I wonder if you could expand a wee bit on what the difference compared to the current one.
Well, it's still in development, so it'll be BSO. So much like we did with the nursing and midwifery framework, BSO will take the lead on behalf of the region. Actually, the nursing and midwifery
very
one,
early stages then?
Yeah, it's a reasonably early stage. I think we're looking towards summer for the new medical dental locum contract to be in place.
Extended, and then hopefully, as Phil mentioned earlier, we're having a workshop tomorrow, a steering group meeting, try and look at an action plan for delivery of that new framework for medical and dental around about June of next year.
Maybe something to leave until further.
Yeah. I should say, just when we're talking about procured contractual frameworks for agency staff, BSO did win an award for the agency nursing framework, and it was a procurement award for how that was dealt with, obviously on a multi-agency, cross-regional basis. So just worth.
Yeah, that's me. Diane?
Yes, thank you, Chair, and thank you for the presentation so far. suppose I'm just going to pick up on points that Danny and Nuala raised. I really find it difficult to understand why the department would not have a target for reducing agency spend, since it is such a considerable spend within the overall budget. And well, maybe I will come and talk to you about it, because I just don't understand why that's. I mean, I know you've said, well, we want to drive down the conditions that create agency spend, and I understand that. But I'm pretty sure that if we don't start to set some targets around it, we'll continue to muddle on as we are, and that I don't think is an acceptable. But just to get on to my question, so it is really good news, and on a day when we've had terrible news about health waiting lists, news that I think we all knew, but it's really stark to hear it again, that we have more people on waiting lists than ever in Northern Ireland. And yet we have an increase over the last 6 years of 16.4 in HSE staff. That increase, when we break it, is 24% for doctors, 17% for midwives. So why, when we are investing more and more and more in terms of staff, and I'm not, this is not a criticism, I'm really glad to see that, but why are the public's access to services so poor?
Well, I suppose that's a difficult question for us to answer in terms of being workforce policy.
But you must think about that as you set a target to increase midwives or whatever part that you're working on at that particular time. How will that improve access to services? And today's figures indicate to us that we have the highest level of people on waiting lists than ever in Northern Ireland. That is shocking stuff.
And I don't think we would disagree with that in terms of those difficulties, and actually, it's a question, I suppose, not necessarily that we'd ask, but that the department would ask in terms of why are we not seeing progress in terms of the waiting lists if there's more people working, and there will be reasons, things like the rollout of Encompass will have, that has a significant impact on output.
But Phil, with respect, we've been using that for a year now since I've come onto the Health Committee. And I understand, because I was with the Northern Trust yesterday, and I've asked them to write to me specifically on the downturn in services and how they hope to make up that downturn in services for the period that Encompass is being installed. And I accept that there will be disruption, but there will be benefit from Encompass. I accept all that. But I don't think the people out there can actually understand, if we're actually increasing doctors by 24%, we're increasing nurses by 17%, and staff increases by 16.4%, which is all good, but we're not seeing a corresponding response in terms to access to services.
And I think we would share that view in terms of our position as workforce policy.
I think I would say we see the success for workforce policy, workforce strategy, because the two main pillars of that were about recruitment and retention, and we know all the pressures that have been on service and professions. So, but these stats we outlined in terms, and they are the empirical evidence there of the growth of the workforce, at least shows that we have made good progress in achieving that element. And absolutely, I think you're alluding to the fact there is a
Does that mean, Peter, that we're working in such silos in the department that we're not talking to the other parts of the department to understand the strategies that you're putting in place, how that'll impact the other parts of the department?
For example, on the workforce planning, the strategic bit, we're aligning it to transformation. So we're engaging with all the policy leads and the rest of the department as to the type of skills that are needed in terms of, because there are new professions coming in, or there's advanced practice and opportunities to bring into play. So we're trying to work with all of our job is to give the tools for the system to deliver. I think maybe is a way of looking at it.
You've just segued into my next question.
Great.
Really brilliant.
Yeah, great, thank you. For Phil, I hope.
That was prophetical. And I was with the RCN, and I was actually up in where the minister was this week. I was there last week in my local GP surgery in Banbridge. And one of the points that GPs were making and the RCN was making is about the skills mix and the issues of professional development and how we actually make people more skilled and actually reduce pressures at different points in the system. And one of the issues was around advanced nurse practitioners. Have you given thought to how we can enhance that and create more roles in that respect? Because I do think that's quite an exciting way of trying to move problems, and sort of see people quicker. Because some of these people are very, very skilled and experienced.
Yeah, sorry.
So Peter might come back, but certainly I think we have a focus on, I suppose, new roles within our workforce strategy, and that will be reflected going forward in our new action plan for next year. And certainly, for us, it's working with the relevant professional lead in the department. So in the case of advanced nurse practitioners, obviously that's CNO's office, but equally there's advanced practice AHPs.
The first contact physios, for example.
There has been growth in some of those areas, and I think our ambition is for that to continue. But it's very much working with the key stakeholders, whether that be the professional leads or indeed the various trusts.
Is that ad hoc, or is there a strategy to do that? Sorry, forgive me if I don't know that, but I'd like to think that there was more of a plan rather than...
Well, I think it's the key element of our workforce strategy in terms of identifying what this got. Because you're absolutely right, then it's not only just having a clear idea of what the service model, delivery model should be, the skills that are required to deliver that, and then that feeds through then to the training, and this can be very often advanced practice roles that you're talking about, for example, the advanced nurse practitioner or others. And those things then all fit in as well to what we're wanting to do about retaining our staff and giving career pathways for staff in HSC. So to answer your question, it is all weaved into all of that as part of our workforce strategy, and we're developing a new iteration of the implementation plan to deliver it over the next 3 years.
And that's very much developed with input from the chief professional officers, because they are the ones who will be driving forward the developments in terms of advanced practice roles, etc. So they're sort of an integral part of our workforce strategy, and we work closely with them to ensure that, as you say, that strategic approach is taken for the different professions.
I just have 2 very quick questions at the end. I know that the 4-year medical course in McGee, but I think that the first set of students should be finishing quite soon this year.
Yeah, the graduation is the 30th of June.
Do we have any indication how many of those students will stay either A in the Northwest or B in Northern Ireland? Or is it just too early? And I'm a bit impatient to know about the outworkings of it.
It's possibly a bit too early.
Yeah.
I think it's
February
be
when they'll be signing up for the foundation programme, UK Medical Foundation programme, which is a UK-wide across all 18 deaneries, including Northern Ireland, and we'll know then what the...
how many are intending to apply for the
and what their preferences, because they would apply by preference for deanery.
But it probably won't be until August that we'll...
For sure.
When people begin that programme, because people can obviously can.
But we'll have an indication.
But we'll have an indication
of that's fine. Now, my last thing is just I don't know whether it's a statement or a question. Is the honest truth. I talked to quite a number of GPs on and off in my role, and one of the things that strikes me is the issue of moral injury. I talked recently to a GP who was very concerned that she was now having to red flag cases that they'd and I left the conversation concerned about her as well, because she was so worried for her patients who were not being seen. Is there a part of what you do that kind of reaches out and looks after? Is that just left to the BMA or professional organisations?
No, so we have a number of things that we could talk about. So we this year, Minister launched a new health and wellbeing framework for HSC, and that's about supporting our HSC employers to sort of, I suppose, benchmark their health and wellbeing interventions against best practice. And so that's rolling forward at the minute. We're also doing a piece of work in terms of the occupational health services that are provided by trusts to their staff, but also those occupational health services are available to general practice staff under SLA, isn't it?
SLA,
with you know, depending on where you are, you have an SLA with an individual trust to deliver those occupational health services as well. So those are provided and available for staff in GPs as much as they are for staff within health and social care.
Thank you. Linda? Controls it.
She should be able to control it now.
Is that working now for you, Linda? Can you do it yourself now?
Yeah, there's it now. Hello?
Yeah, go on ahead.
Yeah. Okay, thank you very much. And a lot of kind of the questions in my head have been answered, but just one that I would like to get an understanding of. There's been an increase in the number of training places for GPs. And I understand, that a significant percentage of those are being taken up by international students, which is very welcome. We always want to see people coming here to work and learn and live. But have we any sense then of how many of those GPs who take up those training places are actually remaining here to work? So are we in a bit of a false economy, I suppose, is the short question, in that we have increased training places, but that does not mean increased GP numbers, because that doesn't work for us. We're not getting the true sense.
Yeah, there's probably a couple of issues just reflecting on terms of GP training places. You're absolutely right. Some of those increased places will be taken up by international recruits.
Philip, do you have a sense of?
And there is always a risk, I suppose, with that people will, want to return to their home countries after they completed their training. I think the other issue in terms of GP training programme that we're being made aware of from NIMNIDA is people working less than full time, and that's sort of an increasing trend in the GP programme, and obviously means less people available for shifts and for delivering service. Maybe Peter.
Yeah, if I may, as you said, this has been a feature that we've recognised in the last couple of years. It's an issue, a pattern rather than an issue, a pattern across all of the National Health Service. And as you say, it is welcome, anyone who wants to come into our system. But we recognise there are particular challenges and opportunities. So it starts with their induction and their welcome to Northern Ireland into the programme. So NIMDA have been actively working on a programme to induct and welcome new to Northern Ireland, we call it, trainees. And that's really helping them find their way around our system, in fact, be able to live here as well, but also as well to understand what the health services and the role that they will be undertaking in the training programme. And that's the specific pastoral and practical support right from the very start. I think as well that there is an opportunity, work we're doing within the GP programme, to expand the amount of time the GP trainees spend in general practice rather than in trusts over the 3 years, and that helps establish the links between a trainee GP and practice environment with the trainees themselves. Because a lot of the things I think ultimately we recognise about people staying will be if they have strong contacts and a really good experience and strong identification both with the people that they've encountered in teams they work with, in the general practices, but also in the communities they serve. So it is, I think you're right to say, an opportunity and a challenge, but it's one that's absolutely firmly recognised by NIMDA. But it is probably fairly early days to assess what the outcome is going to be, but we will be keeping a track on it.
Yeah, I accept. Thank you, Chair. And I accept that it is probably early days, and I can fully understand that. And as I've said, I have absolutely no objection. Our young people go to other places to learn, and it's brilliant experience for them. So I wouldn't want to prevent anybody from doing that. But I do want to make sure that we get a sense of how this is benefiting us. And if it's not, then what do we do to address that? That's not necessarily not welcoming the international students. It's just, do you have to look at them expanding the numbers or doing it differently or delivering it differently? So accept this might be early, but I would like to see something coming back to us in terms of plans or ideas around that, based on when you have more information. So I'm not asking you for that right now, but I would like it at some stage, because I really think we need an understanding, because I don't want us to be 3 years down the line, 4 years down the line and saying we still have a good number of places, we should have enough GPs, but we don't. That's too late. We end up in the position that we're in now, really, and truly, where we have an ever decreasing number of GPs, and it's not working for us. So I really would like to get a sense of that. Chair, that's my only question, because the other questions have been answered, and I think you have been asked enough questions today that isn't within your remit, to be honest.
Thank you, Linda. Alan Robinson.
I asked just a very broad question. When you speak to social workers, they will tell you of, like many within the health sector, of the pressures that they're under, and they will tell you of cases where, or individuals where they are dealing with, and on occasion 50 such cases at a time, and they would wish to see a model where there are a maximum of 15 cases at any one time. And I'm wondering, as part of the safe staffing or the draft safe staffing legislation, will it get down into that detail, or will it be much broader than that? And I know they also say that whenever they left studying for social work, they wanted to be social workers, and they didn't want to be effectively admin workers. They find the number, or the volumes of paperwork that they're having to deal with as well now. So I'm wondering, will it get down into that level of detail, or is it going to be much broader than that?
I think, by necessity, as a piece of legislation, it'll be broader than that. I think the on that kind of issue, it will be about requiring particular professions or particular settings to, I suppose, effectively workforce plan and effectively plan the workload of their staff. So the requirement will be for trusts, for example, to effectively plan the workload of their staff, but it won't get down into a situation of saying you must have X number of cases per worker, because that would be, that might change over time, and it would be too,
you can understand
too prescriptive.
You can absolutely understand how social workers are feeling. I'm just using them as an example, how they feel that they're wishing to leave the profession because of the volumes of work that they're having to cope with. I mean, you're dealing with those cases that are very, very complex,
and I know
that social workers do deal with.
Yeah, and I know the chief social worker is doing a lot of work on that, in terms of improving the working lives of social workers.
Yeah, just to build on that, I mean, declaring interest as a social worker, there are meant to be protected caseloads, particularly for newly qualified social workers in their AOIE year. So from what I'm hearing on the ground, that's not always happening because of the level of demand, particularly in children's services, where a lot of new social workers have no real choice but to go, and then are leaving within that year because of the huge pressure. So whilst on paper it sounds great that we're increasing our numbers, it goes back to my original point around the retention, because we can stream all these new workers, social workers in, or GPs or whatever it may be, But if we're not doing enough, and I'm not saying that's just for you guys to deal with, but as part of workforce planning and workforce strategy, recruitment is an important aspect, but retention I think is even more important. So if staff, and I'm using social workers probably as probably the most critical example, because we're dealing with child protection in essentially, and we are sitting, I think the most recent figure I heard this week was that there's at least, it's well over 1,000 cases sitting unallocated, and that's really concerning because these are really serious situations. That's also, Diane talked about moral injury. That moral injury on social workers is huge. I spoke to a girl just last week, and she worked in the field that I worked in older people services, and I think she said her caseload sitting at around 160. Like when I was in the job, I think we had a maximum of 80, and that's, you know, a mix of lower risk cases, and you would have then others that you needed to be with. But 160 is phenomenal. But if you're adding a significant level of complexity into that, then we're in a really, really, really precarious situation, which we do know, and I think specifically in terms of children's services. So I think that's something we really need to focus on. Obviously, as a committee, we're focusing on it in terms of the social care review, and the conference was this week on that, and Professor Ray Jones's recommendations. But I mean, I think if that's not being looked at, we really need to. We can't just say we're going to just continue to recruit. And I'm not suggesting, sorry, that is the case, but I just don't. I'm not hearing the real emphasis on the need to look at that.
I suppose if we lift it up a level and think about our workforce strategy, and I suppose our workforce strategy has 3 key pillars that we will work with individual professions to develop actions around. So one is recruitment, we've talked about that. One is retention, and the other one is health and well-being. Broadly speaking, they would be the 3 broad pillars of our workforce strategy, and within that there will be individual actions, particularly around, for example, in retention. It will be very much profession by profession, as I said earlier. It's very much focused on. So I know in terms of some of the professional issues, in terms of caseloads and things, Anya Morrison, the Chief Social Worker, is doing a lot of work in that space to try and address some of those challenges, and we work with her when she needs that. So undoubtedly there are, despite all the positives in terms of increasing numbers, we know that there are still challenges. There are some areas which there's a real challenge, even in terms of vacancies. We know that there's some areas where there's challenges in terms of retention, and we've got to collectively, as a system, sort of work to try and develop those actions and those solutions which will address that.
Sorry, Danny, you wanted to come back in before we finish.
One quick thing. Thanks for bringing us back in, Chair. One of the things we were talking about there was recruitment and knowing whether or not people were going to stay following recruitment. One of the things I picked up from the slides is we've quite a few spaces funded by the Republic of Ireland. Is there a requirement on students who come from the Republic of Ireland to go back down and work in the Southern Health Service?
I don't know if there's a requirement. There's an expectation that students who are funded by the Irish government will return to the HSE.
There's an amalgam of things developed over the last 2 years. Last year, 23-24 intake, there was an issue that we're not able to fund. The Minister Secretary wasn't able to fund the number of places that he would have liked to have, and the Republic of Ireland approached us and able to train for them, their staff, as a compensation against that. As part of the arrangement, they funded 50 places on nursing programmes for Northern Ireland domiciles, plus another 5 for allied health professions. So that was a net positive to us out of that. So it was really to use the capacity, the spare capacity that's there in the system, particularly in Ulster University, and it's important to preserve that for our wider good here in Northern Ireland. And the most recent then arrangement that's been agreed this year in respect of, again, some nurses and also allied health professions, they would be for Republic of Ireland domiciles, but in a sense they were people who might have been attracted to come to our system in a range of our programs anyway. So we've been able to expand it to enable that cohort to be trained in our system. But it's, again, essentially it'll be for the southern system. But it's ultimately it's a win-win for both our systems, and it's something I think our minister is keen to look at, looking for opportunities for collaboration on the island in the space of the education of healthcare professions, because I think probably collaboration is better than ignoring each other or competing across the systems.
Mm-hmm. Thank you.
Okay, and final point, Linda. So you take one back and then you start a trend. We're going to go round again.
I'm sorry, it's a very quick point.
No, go ahead.
It's actually a very quick point on the last point, to be honest with you. I don't think there is a requirement on them. Just from discussions that I had at the time whenever this took place, because it was when the assembly was down. But I do think it's a good thing that we retain those places. That actually allowed us to retain those training places. So if we needed to rebalance that and we were able to train more people from here and we had the funding to do that, that can be rebalanced. But I actually think what was just the last point that was just referred to is really important. It's that collaboration, because that is exactly what we need. We need for the flow not to be all the other way. We need for the flow not to be all heading south. We need there to be real, genuine collaboration where we have people who see their role being expanded in hospitals and healthcare facilities in any part of this island, that's where they want to go, because that's where they're going to actually reach the peak of their professional life. So I think we just need to have that broader picture of all working together and making sure that every single person on this island gets the best healthcare service possible.
Thank you for that.
Thanks, Chair.
Thank you all. I think that's definitely been very useful for us, and it'll feed in nicely to our next briefing around transformation. So we do appreciate all your time. Thank you.
Thank you.
Okay, members, thank you. So our next briefing then is an oral briefing on reform and transformation of health and social care services. Just to refer you to tab 6 of your pack, which includes a written briefing from the department providing a high-level position on the reform and transformation of health and social care services at page 66, and the hospital reconfiguration document summary at page 70. If we could also draw your attention to the written briefing at item number 7, page 221, regarding mental health and cancer strategies and stroke action plan, as this is also relevant to the transformation agenda. So you may want to ask questions to that in relation to transformation, just to keep it relevant. Peter, how are you? You're both very welcome, and thank you for your patience. We have in attendance Peter Jacobson, Director of Regional Health Services Transformation, and Michelle Essler, Head of Transformation Branch. We have about an hour for this session, maybe just slightly under an hour at this stage. So if we could ask you to make some brief opening remarks, and then we'll go into questions, because we have a good briefing paper there as well. So thank you.
Yeah, sure. Thanks, Tara. So as you know, we issued a short briefing paper just in advance, and which focused on the hospital network consultation. And in terms of the open statement today, I'll just maybe briefly reflect on the recent Bangor conference, and then also where we are on the wider reform agenda. Then I'll say a few words about the hospital network consultation itself. So starting with the Bangor event, I maybe focus on the key takeaways. So I mean, one of the key points that came across, Professor Bangor is very clear that the health and social care systems everywhere are grappling with the same issues that we are. All health systems are facing increasing demand due to demographics, greater case complexity and advancements in medicine. And a clear message was that we need to accelerate the shift left, and that means focusing on prevention and population health, and on building up capacity in community services, primary care and social care. And a stark message was that if we don't make those changes, health will eventually swallow up the executive's entire budget. So it's important to recognise that reform is not a silver bullet that will solve everything. We can't get away from the fact that we need additional capacity, for example, to tackle the backlog in the waiting lists. And changing how we how we do things can certainly help, but it has to be accompanied by investment in more capacity and a real focus on productivity. So we need both of those. So moving ahead with this agenda requires strong leadership from all parts of the system. And it feels as though everybody's up for that challenge, but I think the Bengo event was helpful in encouraging that. So with that, I'll turn to the hospital network consultation. You all hopefully have had a chance to read that document. So I'll not go over the detail, but highlight that a key purpose of the paper is to set a strategic context for future reconfiguration decisions. And the document therefore does not in itself contain any specific reconfigurations. And that's because each such decision will be highly complex, will require detailed analysis, engagement, and most likely its own public consultation. So the document was co-produced with the Trust, NIAS, and the PHA, and it's important to recognise that there was significant clinical input to that. As you'll also be aware, we undertook a pre-consultation engagement exercise with the Royal Colleges, the trade unions, and with a group of service users. And following that feedback, we made some changes to the paper, recognising that actually much of the feedback will probably be addressed as we take forward actions after the consultation has concluded. We also, as a result of the feedback, worked with a group of service users to co-produce an easy read summary document, which has also been published alongside the main paper. We are now working with each of the trusts to organise consultation events in each trust area. And the first event will be in South Eastern Trust, and details will be publicised shortly on that. And the others will then follow as soon as we have dates and venues confirmed and identified. And following consultation, we'll analyse the responses and provide advice to the Minister on the next steps. And I'm pretty sure that'll incorporate some recommendation on how we progress the proposed actions within the document. So, Chair, that's all I want to say, and I'll be happy to take any comments.
Thank you, Peter. I suppose just, and it ties in with the question that was raised with me this morning. In the briefing paper, you've outlined the Minister is planning to publish his 3-year plan. I know it says it's in the coming weeks. That could mean anything in politics.
Yeah.
Do we have any sense of when we're likely to see that? And what sort of detail will be? You know, we've had the reconfiguration document, which is very high level, and obviously there'd be more meat in the bone as we go through that process. But in terms of a 3-year plan, I'm conscious that we always get lots of plans. I'm not being critical. I suppose just to get an understanding of it, because I know the seminar I attended this morning, a lot of the health leaders in attendance were very keen to hear more about that, when we would see and what that will look like.
So we hope to get out before Christmas, but all depends on obviously what Minister thinks of it. Okay. So we are starting to engage with the Minister on it now. He might well want some changes. That might mean it takes longer, but we hope to have final drafts with him quite soon and have a discussion and then take it from there. So hopefully quite soon. If not before Christmas, then certainly I would like to think sort of for January. But in terms of the contents, I suppose it consists of 3 parts at the moment, again subject to Minister's views. There's a narrative kind of that sets out a bit of a context, summarises some of the key kind of outcomes we want to achieve by year 3 of the plan. And then there is an annex which sets out kind of links to all the major reform programmes that are underway. And then a second annex was probably the detailed plan then, which have actions across all the various areas under 3 domains really, delivery, stabilisation and reform. So we created sort of actions under each of those headings for each of the years, and I'll set out in some detail about what we plan to achieve. I think it's important to say currently the Minister's very keen this is ambitious, and as you know the budget position is really, really difficult. So it's hard to be very ambitious with actions if you haven't got budget for it. So some of these things will be subject to budget. I think that's the only way we could do it really, to try and set out what we want to achieve. So we try and distinguish between what can be achieved with the budget we do have and what can be achieved if we get additional budget. Bear in mind, we don't actually know what our budget is going to be for the next 2 years.
And in that, just as you're talking, I'm thinking this, I'm under the impression that the Finance Minister, the Executive, will be looking towards a multi-year budget for, I suppose, the rest of the mandate. Is that something that would then be factored into that plan?
So,
if you know, I know it's difficult because we don't have it at this stage, but I'd like to think that there's some level of planning around that if and when that becomes available, what we could do with that.
Then we need to do a refreshed plan. I think if you're going to publish in before Christmas or so in January, so we won't have the budget yet, so we won't. But I think what this will do is set out if we get budget, clearly they'll set up what we will do with that and what we can achieve. And how much of that we achieve then depends really on how much we get of that budget.
Okay, I know that's probably a wee bit of
it's
a
difficult because I suppose you could always wait then and keep waiting for the next budget event.
No, absolutely. I take that point. I suppose I'm just thinking of, I would like that if we were ready, that's maybe not possible at this stage, but in the event that that the kind of foundations are there, that if a multi-year budget was available, because I'm conscious of how long's left of the mandate as well, and that has to be factored in. But no, thank you for that update, Peter. Peter, I suppose then on the communication and consultation around particularly the reconfiguration, in the document it mentions the PPI framework. Yeah. This particular piece of work will impact people right across our communities, and I suppose I want to ensure that we're doing everything that we can to ensure everybody's engaged to the best of our ability. I know that's not always easy, but I suppose where there changes may happen that will probably affect more people who are in more rural ends of our constituencies and things like that. So I just would like a wee bit of an understanding around what that engagement looks like. You mentioned the events, consultation events, but what else is being done in terms of that engagement and consultation? And are there other things we could be looking at? Because I'm thinking particularly of our elderly population, people who maybe don't have access to online, whether it's broadband issues, those types of things. And I don't ever want to be in a position where we're on the other side of a consultation, a small portion of society have fed into it, but those people are probably going to be impacted the most, or don't have a full understanding of what exactly it is, haven't had that opportunity. And I know it's not possible to get to everybody, but I suppose I'm just trying to think of ways outside the box. Is that included in that framework?
Yeah, so you talk about consultation on the framework or the document itself, or future configuration decisions?
Well, that, and I suppose that wider reform piece and transformation, because any change can be difficult to manage if people don't fully understand it. So I hope that makes sense, but it's just what I was talking, I suppose, specific to what the engagement and consultation looks like from the department's perspective.
Well, for this document particularly, we obviously have an event in each trust, and we're working with the local trust on those. So they're going to be publicised, and they're going to. So they have reach outs into their local communities, and we'll publicise it through that, and we'll do it through our departmental channels as well. We'll work with PCC as well on this. So we're going to try and reach as many groups as we can that way. In terms of, we're going to do an online event as well. Obviously, I might not reach the ones without broadband, but a mop-up online event for those that misses the physical events. In the future, I mean, the commitment to PPI is very clear, and there's a statutory duty on public bodies or health bodies to do that. So that this doesn't change that. That'll have to happen, and each individual decision, if it's taken forward by a trust, will have to be taken forward, and there has to be full engagement on those.
And I think that's why we did the summary document with the service users, because we recognise that some of the language might be clinical, might not be fully understood, so we tried to make sure that the 80-page document, then we had the 10-page summary, which then we'd target, and we ran that past service users, and it came back with very positive feedback that, that now makes sense to me, what you're trying to say in that bigger document.
And I suppose, Michelle, that is key to what I'm thinking around, and it's looking at service user groups out there that are in, maybe if they're attending hospital or attending clinics or whatever it may be, that there maybe is an opportunity for people, whether it's our staff and things, to encourage people to get involved, and likewise as elected reps as well. I suppose moving on then to the challenges, because that is the key part of all of this, is yes, we know what we have to do, and again that message came across very strongly in the conference this morning. We all really know what needs to happen, but it's how we get there. And workforce, I think, is probably one of the critical elements of that. In the previous briefing, which you may have heard some of it, we did speak to some of this with officials in attendance, and Diane has pointed out the increase from 2018 to now September this year of 16.4% to our workforce. However, we're hearing today that still over 500,000 people are sitting on waiting lists on a first consultant appointment, with more than half of them waiting over a year. So we understand the challenges that exist fundamental challenges in workforce. We see the vacancies, it's well rehearsed at this stage. And I suppose what I'm trying to understand is what impact is that having where we are seeing an increase. I think to quote Phil that was here, he said we have more staff working for the HSE now than ever before. Yet we've got the worst figures. So it's trying to get an understanding of that and how that ties in with that bigger transformation piece. The Minister has said transformation has been happening, albeit it's at a slower pace than any of us want. But I suppose, and it ties in then with the introduction of elective care hubs and the mega clinics, which for me we should be seeing those waiting lists coming down, not going up. So if we could get an understanding, even if you can, around that, because
So again, I'm not leading on like the care side, so I'll tell you what I know, and you might have to pick it up, or we might pick up more in writing. But part of the issue, so the department was quite clear this year. For example, we needed well more funding than we needed even to stand still. So part of this is just that you don't have the capacity to even deal with the demand that's coming in. I think I can't remember the exact number, but I think it might have been 130 odd million we needed
135
to stand still, and we got 70 odd. So that's part of the issue. And then there's obviously a further investment needed to tackle the backlog, which wouldn't be ongoing investment. It's a kind of a non-recurring investment. If you can have that for, again, in excess of 100 million for 5 years, you could probably tackle the backlog. But until you have that extra capacity, we're not going to make inroads into the waiting lists. Despite the transformation that's happened, and I think there's also, and I think Minister said this before, there is a need obviously to get the most from what we have. So we have to really focus on productivity, make sure that the centres we do have deliver the most they possibly can, and that's just an ongoing focus, particularly by SPPG on the productivity challenge.
Yeah. And I recognise that. I suppose what I'm saying is, are we measuring then? We talk about the rollout of MDTs, and I know I'm not saying to be specific to anything. I suppose on overall, we have seen some rollout of MDTs. Likewise, the elective care hubs, likewise mega clinics, which are all there to try and alleviate pressure in the service, make sure people are seen quicker when they need to be, and essentially, I would hope promoting better outcomes for patients. So are we measuring what has happened to date, that those small elements of transformation and the impact that's having? Because surely that is, if that's having the impact it intends, then we should be making savings. I know that's easier said than done, but I just think we have to track this very, very closely, because if we want to make the arguments to ensure we're getting the funding needed, the evidence base has to be there, and it is there. Particularly around MDTs, we can see already that it's freeing up appointments, and those will all lead into addressing the workforce challenges that we're hearing so much about as well.
My understanding is that we are tracking the amount, obviously the throughput for all those various clinics and the mega clinics and the day centres, etc., and the impact they're having. So that information should be there. I haven't got it to hand.
Yeah, no, okay. It's maybe something we can pick up, because I would like to get a sense of what that does look like, because one of the quandaries I always find myself when I'm having conversations with people is, we know we have to tackle the symptoms, right? So that's the waiting list, that's the real critical issues that are upstream. But can we do that and transform at the same time? We have a budget of over 8 billion, and we're still saying we need a hell of a lot more. Surely within that, where transformation is already happening, we're starting to see the benefit of that. So, I mean, from your perspective, Peter and Michelle, I mean, do you think that in the current situation, transformation's essentially on hold or very, very slow pace because of the need elsewhere, or is there an ability to walk and chew gum at the same time, to put it nicely?
No, I mean, it is happening as we speak. So for example, over the last couple of years, we put in place urgent care streams and urgent emergency care, for example, local phone first services. They are new services that have been put in place, and we also expanded on what's called same day emergency care. It's designed to take demand away from EDs. Yet we are seeing huge pressure on EDs still. So part of me is that there's something about understanding the increase in demand that we experience, because one is, if you have more staff and we aren't seeing the outcomes we want to see, Well, one explanation could be that demand has increased by the same amount or more than the staff has increased. I don't know that. I don't know if that's the answer, but that's one logical explanation of it. And I think certainly we know that obviously people who are waiting on the waiting list will probably see their GP more often. They might end up in ED more often than otherwise would. So there's something about the connectivity. It's hugely complex to try and track that. You probably can't. But there's something there about the pressures that we're under, partly probably explained by the long waiting list, for example. So these things are all connected.
Yeah, they absolutely are. And I mean, you've said it there, even in the example around someone on a waiting list seeing their GP on numerous occasions, maybe presenting to emergency departments. That's adding into that pressure. So when we're not doing the transformation needed, we're actually increasing the cost, on other elements of the service. So, no, I could probably go into a few more, but I don't want to. I want to give members time as well. So I have Colin. Waiting here, Colin, for you to be unmuted.
We can't
That's
speak.
you now. That's you.
Sorry, just to reiterate again, and maybe we could have the technology looked at. It does take about sort of 20 seconds before we're unmuted whenever we're online for some reason.
We can see when you are unmuted, so I knew you couldn't be, but yeah.
Look, my question really is just about, I suppose, in terms of transformation, what is transformation? Where is the overall plan, and is there an overall plan? I mean, I get a sense in my head, I'd like to think that there's a room in Castle Buildings with a massive table that has it all mapped out exactly what the transformation is actually going to be, and that somebody is keeping an eye on that, because, I mean, we hear about changes to children's services, suggested hospital networks, elective surgeries, emergency departments, mega clinics, phone first, urgent care. Maybe people having to travel to get the better service, not necessarily about it being the close to them. But then alongside that, and it's probably following on, Chair, a little bit from what you had said, the GP out of hours reconfiguration in Belfast, is that transformation, or is that a collapse of a service that needs to be amalgamated because it can't get the staff to deliver both sites? Northern Ireland Ambulance Service are talking about reducing in the Eastern Division their ambulance cover at night time from 9 ambulances and 11 at the weekend down to 6. Is that because of transformation, or is that because there isn't the staffing available to provide the service as they currently do? We know about Daisy Hill's maternity hospitals. We know about the reconfigurations at the SWA. Are these transformation? Because people on the ground are not thinking, they're not feeling like it's transformation. They think that those examples are a collapse of a service, and we're constantly told that we have to sort of to suck that up because there's an overall transformation process. But is there one plan that has multiple elements to it that is available, that we can sort of say transformation is going to start here, have this amount of money put into it, these things will be delivered, and the service will look like this at the end in a transformed way, so that people can see what they're actually part of, what that process is? Or is it just a bit here and a bit there, and people working in different ways and different things?
Okay, there's quite a few questions there, so I'll pick up maybe the first bit is probably there is a plan delivering together, and there was an update published in June this year which pulled all this together in one place. That kind of summarizes all of the various bits of transformation that is happening across the department, and you would probably recall there's a whole range of areas in there. I don't have a sort of a control room where we have all this in one place. No, I don't, Colin. But I think there's obviously lots and lots of different review strategies that we've published in many different areas. I just think it's too complex to try and pull all together in one big piece, because it becomes impossible to see all the connections. But what we are doing with this 3-year plan that we mentioned is that we're setting out over the 3-year period what we are going to do in 3 domains, and one is stabilization, one is delivery, which delivery is really about how do we get the most from the system, and then the final one is the reform bit. So that'll set out the actions that we are trying to take forward in the reform or transformation space over the next 3 years, So I think that'll probably be a good place to have that in one place. Here's the key things we're going to do. That's probably as good as we have in terms of kind of a one place of having it all together. But I take your point, but I think it's so complex and so many interconnections that it becomes very difficult to have one kind of.
But when we say a collapse of a service, is that registered somewhere as a collapse of a service as opposed to transformation? Because quite often the argument is, oh, you're complaining about something that's a transformation and everybody's supposed to buy into it. But there is a fundamental difference between the transformation of a service and a service that collapses because it's not able to survive in a safe manner. And I think that there is that distinction between the two. Is that distinction recognised within the department?
Yes, I wouldn't classify a collapse of a service as it's certainly not planned transformation. It clearly isn't. It's a reaction to a set of circumstances where you can't maintain that service anymore. I wouldn't class that as transformation. I would class that as you say, something that needs to be done for safety reasons. Obviously, if it's a proactive decision, say you have a service review that looks at a particular service and you identify vulnerabilities in that service, you might take action up front to put it on sustainable footing to try and deliver the best outcomes for patients that is sustainable long term. I think that's transformation because you're making the service safe. But I think it's a reaction to a collapse. I wouldn't class that as transformation. I think it'd be difficult for me to classify it in that way.
Well, just finally then, just sure if I can, if that is the case, should trusts be reacting to an inability to be able to provide a service by reconfiguring it and making it planned to look like it is in some shape transformation, if then that individual service that they're delivering with their trust needs to be part of a wider Northern Ireland-wide approach where it then may be pitched in with others? Because the Minister has been quite clear that whilst there may be 5 trusts and he doesn't want to go down the avenue of removing that and turning it into one, he wants to look at services on a regional basis. So is there somebody checking that if a trust is tweaking its service in one area to make sure that that doesn't then impact the capacity to deliver things on a regional basis?
So there is a process the trust needs to go through and engage through SPPG in this. And as part of that engagement, the SPPG will work with the PHA to check and actually trusts are required to work with other trusts that might be impacted by the changes to make sure that regional picture is taken into account. So that's baked into the process.
Okay,
that should happen.
Yeah, and Chair, my apologies. I have to go to a ministerial meeting with South Down representatives, so it's at 4:00. So thank you for the question. Thank you, Peter, but I'll have to leave the meeting shortly.
No problem. I know there's 2 others I think have to leave. Linda and Nuala, do you both have to leave at 4?
Yeah, we're both doing the same policing board and thing.
If I could ask Danny, if I could take them first, is that okay? So I've Nuala and then Linda.
Oh, me? No.
Yeah.
And I just then have one question because I'm really conscious of time, is that what data analysis is taking place for the services that should be run within each reconfigured hospital in terms of ensuring that there's improved outcomes for each people. Essentially, who's making the decisions based on what goes where, and is that being done by using some sort of data analysis, and if so, what? And
I think the answer is it all depends on what the service is. And depends on the nature of the change. So I think as the document sets out, some changes will be trust-led and trust-initiated. So you have, for example, let's for example take the change in South Eastern Trust to move the urgent care service onto the Ulster site. That was trust-initiated and trust-led. They did a lot of analysis around that, obviously around travel times and impacts on patients, etc., etc. And they discussed and shared that with colleagues in SPPG, and the PHA also then came in. So all the analysis is there to support that decision.
How can this be trust-led if the Minister is saying that it's one trust in his mind and that's the way he wants to look at it? If we are going to have a system where it is a region-wide, how can we take that power away from it just being trust-led to actually being elsewhere? Because otherwise, how will we actually ensure that the transformation is taking place if it's led by each individual trust?
So I said that there is this baked into the process that when a trust initiates a change, they'll need to identify what impacts there might be regionally and then discuss with the other trusts as appropriate. And in fact, it's something that ASPPG and PHA will also check to make sure they've done that and that analysis is sound. So you'll know, let's take the maternity service in Causeway as another example. Clearly there's an impact probably on Eldergavin, because some of those mothers will probably go to Eldergavin instead of going down to Antrim from the Causeway. So again, that needed a obviously an engagement with amongst the trusts. Again, that has been quality assured and checked by SPPG and the PHA. So that process is there to try and facilitate that cross-trust working.
Shouldn't it be the other way around? Why isn't it the other way around? Why isn't it Department SPP trusts?
I think it depends on the change. If it's a local change, then you might be able to contain it within the trust or across two trusts. But if it's a Northern Ireland trust,
all of it, when we have region-wide, we have acute.
And so if it's a region,
So there are regional reviews.
Yes.
That where it's departmental led, and that will take an overarching regional approach. So examples of that would be the neurology review, the ongoing work around stroke reconfiguration, elective care framework.
Would be Northern Ireland wide.
So it's all led by. So we are given the assurance that it's all led by data, of course with input, which is essential, but it is all led by the data analysis, which is important.
Yes.
Yeah, part of the decision making.
Thanks, Neil. Linda?
Thank you, Chair. And thanks for the answers so far, Peter and Michelle, appreciate it. Just in terms of the transformation piece, and I acknowledge that it does take extra money in some services, but we know that there's money there to be saved. One of the issues that was actually raised with us last week by the trusts was the failure to attend appointments and the cost of that to every trust and to every service. And rightly highlighted actually by Deirdre Heenan was a comment made by Neil McGuckin around that he thinks, and it seems to be anecdotally without any evidence, to be honest, that there's an issue around affordability to get into appointments. So with transformation, we need to ensure that people can actually access the service or the appointment that they need to get to, or that whatever it is they need, whether that's a treatment or diagnosis, that they can actually access that. But I think we also need to get a sense, and I know this would need to come from the trust, but I think that it's something that needs to come through the department to us. Chair, probably maybe something that you could pick up is, can we find out, does each trust collect any evidence around what are the reasons for failure to attend? Have they looked at the best practice examples? As I say, some of those were actually given in some media interviews that were done during the week. So there's no reason why we can't look at those, or trusts can't look at those, or the department can't look at those and see if we can get to the bottom of those issues, because that has to be part of the transformation. You can't reconfigure and transform without any understanding of whether people will actually be able to access the service. So for me, I mean, it goes back to your point, Chair, at the beginning around people in rural areas in particular and how they're going to access service. But in fairness, if you live in Belfast and the service is in Enniskillen, the transport in Enniskillen is pathetic. It doesn't matter which direction you're going. So if you're going from Belfast to Enniskillen, it won't be any easier for you to get there as it is for somebody to get from Enniskillen to Belfast. So I think we have to acknowledge this as a region-wide problem if we're going to be putting services in different places. It's what I want to see actually happening, but I want to understand how people will access the service. And, Nuala's point is well made, and it's actually a follow-on from that as well, is how are we going to understand the outcomes for people? And that's the outcomes for everybody, not just those who actually access the service. What are the outcomes for those who maybe, for whatever reason, are unable to access it? We need to know that, because without that data, all we're getting is there's better outcomes for everybody who accessed it. What about everybody who didn't or wasn't able to because of how we transformed? I'm not saying that's going to happen, but if we don't collect that data, we won't know.
No, I noted the comment Neil made as well, and I think it's something we need to get to the bottom of. I mean, Neil wouldn't obviously say that without some anecdotal evidence in his own trust that it might be happening. But I suppose we understand the scale of that. I don't know at the moment. It could be a few isolated cases. It could be a lot more. And the only thing I'll note, there is a travel to hospital scheme that supports people on low incomes with the travel costs. But there's obviously a threshold there, and people can access that. But that's there. Is all I'm noting. So those on the sort of lowest incomes will have support.
Linda, is that you?
Yes, sorry, Chair.
No problem, thank you.
Sorry, no, it's not.
All right,
It's not.
okay, go, you're all right.
It's just a very quick point. I get what you're saying, Peter, and that is a good scheme for those who are in low incomes, but it's not everybody who's on a low income. It's the accessibility, actually.
Yeah.
So it's not just about the financial impact. So yes, Neil made that comment based on potentially anecdotal. I would like to have actual figures of what the actual problems are, and that's not to say that doesn't play its part. If it does, we need to figure out how to address it. What I'm saying is that has to play its part in a bigger transformation plan. We cannot transform services and put them wherever and then say, now we'll worry how we get people there. It all has to be part of the plan. So I'm not saying that's all on you. That's departments working together as well. But the health department has to tell the other departments what it is they need from them.
No, couldn't agree more.
So it's just getting a sense of that, I suppose, and if we can follow up on that, sure.
No problem. Thank you, Linda. Danny, and thank you for...
No, you're grand. Thank you, Chair. Actually, some of the points that I was going to raise were addressed by Nuala and Linda there. So, but I wouldn't mind just building on the first one. I think it's about the vagueness, and a couple of us have expressed this. There's very little detail in the plan that we've got. Yes, it's open to consultation until February. When are we going to see more detailed plans? What is that going to entail? And I think you'd hinted at it there, Peter, earlier on when you said that there may be further consultation. So to each of the decisions that we're going to see, is that going to require a further period of consultation on each of the decisions laid
Specific
out?
decisions, yeah. So you'll see, for example, Northern Trust is out for public consultation at the moment on their general surgery. That's one example of that. That is a reconfiguration decision they are actively considering at the moment. So each individual future decision like that will require its own public consultation.
So when will we be getting a more detailed plan?
Well, this is an ongoing phase. This will continue. So at the moment, trust will react to even changes in population needs and so on. That might change how you need to configure services over time. So I don't see this process ever ending. I see this as an ongoing thing that decisions will be taken as and when they are required.
But this plan for reform at the minute, it must have a timescale. It must have an end point. What are
I think what we said is that what we set out in terms of describing the system and the core services. So some of the core services, for example, we talked about general hospitals, which are the sort of the three, SPA, Causeway and Daisy Hill, will need their type 1 ED, the 24/7 ED for the foreseeable future. We did say, I think we say at the end of this is obviously not a forever document, so we need to review it. At some point, I can see this needs to be reviewed in the next 10 years. And maybe review all that, but I think that's kind of the time scale. There are some reviews in the department coming up, so there's a piece of work on stroke reconfiguration. I think you had some briefing on that. I think that's one of the next sort of departmentally led decisions that need to be taken around that. There is a review of neurology services, which is ministers actually agreed that we take steps now to prepare for public consultation on that. So another one will be coming out. So there will be things that come out from the department. At the same time, there will be some reconfiguration decisions come forward from the trusts, I suspect, over the next number of years.
Specifically in relation to the hospital network, there's no date that we're aiming to see a more detailed plan at the minute.
I don't think we expect to have a more detailed plan on when decisions are going to happen, but what will be taken forward is the actions within the document will need to be taken forward. So I think there's 13 actions in there. So we'll need to take them forward, depending on obviously the feedback we get from the consultation. They are not specific decisions, but they are things that should aim to help or support the system working better. So those actions need to be taken forward. So we'll need to set up arrangements to oversee that and take those forward, identify action owners. So I can see an action plan coming out of this after the consultation finishes.
There's no timescale for that.
Well, so we will need to then obviously the closest in February. So I think we'll need to the spring to analyse the consultation responses, get that to the minister and get that signed off kind of next year.
And then the timing will be the stakeholders and the action owners of rather than us saying we want you to do it by this time, it will be when can they get involved, and some of them will hopefully be quicker than others, but some of them might take.
The trusts?
Well, trusts, clinicians, royal colleges, trade unions, it'll be anybody affected by whatever the action covers. Even on the travel one that we talked about will be what help we can get from Department of Infrastructure, or volunteer drivers, or other aspects to the transport side of things will be wider.
And each of those actions is going to require consultation as well then?
No, they won't.
It depends on what the
I don't think so.
is.
Well, maybe
it depends on what they are.
Suppose
some of them will.
Some of them will.
Well, that might be true. In transport policies, one potentially significant changes might require a public consultation. Some of the other, I don't think will. So it depends on the action. For me, probably the most tricky one is probably around the, going. So we are saying we need to make sure we can deliver services that are, equal access to services across the system. And we know, for example, from the Neurology review, that there isn't equal access to neurology services in hospitals. So there was something about working for each speciality to work out how can we best deliver for the population in the most equitable way. And that requires obviously each clinical, I suppose, profession to take leadership of that. And that's, having gone through it with the Neurology review, it's a long process. Okay, so there is an action plan to be set out around how we can deliver on that.
Well, I appreciate that, and we hear time and time again, we need to reform, we need to reform, we need to reform. So as a committee, I think we need to see the plan for reform, and what we're hearing is the current plan is quite vague. We're not going to get a detailed plan for, it sounds, about a year. Then all those actions that will filter out, they're all going to have to be consulted on. Some of them will, some of them won't. So this is a very, very long process.
Yeah, it is.
We want to support reform, absolutely, but we need to see some details. We need to know what that means across Northern Ireland, and we're not seeing that.
I think I would go to the Deliver and Together progress report, because that follows on where the idea of reform came from in 2016, and then the Deliver and Together gives you a long list of things that have been progressed, and then next steps. But I accept it's not an overnight reform.
No. Just into the points that Nuala and Linda were making about the data as well. The point that was made by Neil McGugan last week was very hard hitting. That there were people who were not turning up for operations because of the financial impact. Now I know it's been said that that's anecdotal. Do you record the reasons? Is there reasons why people come off waiting lists? So that we have data and so that we have understanding as to why that happens. Is there any?
So I don't know the detail of that. You might have provided some information before on this, actually.
I think the last time we were here, we were asked when people came off the waiting list, was it because of her private
We did.
appointments?
For private
and
appointments.
we couldn't get.
We didn't have that detail.
And we couldn't get the detail. We
I had asked that question.
Yes.
And there was a couple of other possibilities that maybe the patient had moved away, the patient became frailer, the patient had sadly passed away, or they'd gone private.
That's not recorded.
That's not recorded anywhere.
I think that was the information we came back with.
I think the trust in terms of cancellation are trying to manage that, because obviously that can then help with efficiencies and capacity, and it's something where they want to go is understand the cancellation. So I think they are trying to look at that. I think the bit about why people come off a waiting list, I think we don't necessarily have all the reasons for our capturing that.
One of the things I hear anecdotally in my constituency is that constituents are being forced into going to the independent sector because they fear that they're going to be waiting for years. So we don't know how many of them are then getting their operations privately and coming off the list. That's not a figure that
We can ask
we'll
again.
go back to see what the answer we gave you last time. I can't
I think
remember,
that was provided
but I
in
don't
writing.
think we had the detail behind it.
My recollection of what we provided in follow-up
Yeah.
from it was that wasn't available.
No.
One last thing I just wanted to follow up with you was, well, it's on the mental health strategy. The briefing that we've had, the written briefing that we've had on the mental health strategy, it makes it very, very clear that the mental health strategy is not being funded to the required funding levels. And some of them are, they are quite shocking in that last year £24 million was needed, but 5.5 was allocated. This year £42 million is required and 5.9 million has been allocated. Now, I absolutely understand there's financial constraints on the department, but these are very, very concerning figures that we have a mental health, an agreed mental health strategy and a plan for rolling it out and a funding plan, but it's not being rolled out. Is there anything that you can tell us about how this is impacting?
Sorry, I can't. I don't know. I'm not involved in the implementation of the mental health strategy or even decisions around funding. That clearly sits with the minister, so that's beyond my pay grade. Yeah, no.
We can maybe do it in the next, under that briefing, we write the minister on that. If that would
you
be
can follow up in writing. I'm sure that we can.
to the minister, yeah.
We can
I appreciate that. Thank you.
Is it, yeah. Okay, Diane.
Thank you, Chair, and thank you for the information so far. Given the last conversation with Danny, do you think reform and transformation will ever happen?
It is happening. It has been happening already.
Do you think we'll ever see the kind of big changes that we need in terms of reform and transformation? I must say, Peter, I was kind of surprised and a little bit depressed by your sort of no, we don't have a big plan, and we're not ready to produce one with more detail. There isn't a lot of difference from the original Bangor report to the document that came out in October. There's not that I can see anyway. There's not a lot of difference, and there's certainly not much more detail. And we're now into 16 weeks of consultation. Then you're going to tell me it takes to the springtime before you've analysed that consultation. And then a further period of time probably until you get the actions and from that.
That's
in this mandate, what are we going to see in this mandate?
Okay, so I think we're probably talking about different things. So certainly going to see. No. Let me explain. So I think what we're going to see, we have the 3-year plan we're working up. I think that's where you're going to see the deliverables in this mandate across not just the hospital network piece, but across all the various pieces of reform that's happening in the department. So that's being pulled together at the moment. They'll set that out. So that's, I suppose, that is the 3-year plan. Specifically on this is about how we make our hospitals work better together as a network, and the actions are designed to try and encourage that and facilitate that. So on that, as I say, yes, I mean, we will have to obviously take a bit of time to analyse the responses, reflect on the feedback we're getting, and then provide advice to the minister. That's going to take a few months with a very small team that has a lot of other things to do. So that, that I think that's normal practice to do that, and then an action plan will come out of that. But the action plan is actually more about making this a hospital system work. It's not about the individual reconfiguration decisions that might follow.
I suppose what I'm worried about is, as the chair said, and as I asked our previous participants in this committee meeting, that's not much good to the 500,000 people that are on a waiting list, the biggest ever waiting lists that we have had in Northern Ireland. And I'm looking for some urgency. I know there's a process, and process is good and protects people. I accept that and I understand that. But I am looking for some sense of urgency around the issue of transformation so that we start to deal with things better. I just move on because I don't want to take up too much more time. You talked about the Northern Trust. Now, as it would just so happen, Alan and I spent almost, I don't know, an hour and a half, 2 hours with the Northern Trust yesterday discussing the proposal to move emergency surgery to Antrim and have an elective hub on the Causeway site. And whatever the merits of the overall, and don't want to talk about those, but what I want to talk about is the reality of the vision and the planning assumptions that they make in trying to realise that. So it emerged as we were talking in the meeting and having a conversation about it, that there were a number of planning assumptions within their proposal and what they wanted, their preferred option that they wanted to see. There were a number of planning assumptions in that. And one was on ambulance journeys between Causeway and Antrim, which we all accept will increase because of that change or proposed change. And when I asked, so what investment, what work was being done with NIAS to actually make sure that there was an ambulance fit for purpose, and I paraphrase, so it's not an exact quote, but this is roughly what was said. Well, we're still working on that, but it'll be no worse than it is now. And I was actually talking to a GP the night previous from the Northern Trust, who told me about a man waiting 16 hours to get to Antrim. So what I'm saying is that we cannot make change, and change is not, and change is good. Change is okay if it's going to make things better. But if we, and it's a bit of what Linda said as well, if we don't actually underline that change with proper planning and proper investment in services, then it's not going to be any better. Second planning assumption in this was the need for additional beds in Antrim. So how are you going to get those? And I then asked the obvious question, how many beds in Antrim were unavailable yesterday because of the lack of provision within social care? So 26% of all beds in Antrim Hospital yesterday were unavailable. But we are trying to create extra beds for this issue, for their preferred option. So how are you going to get that investment so that you clear more beds? Well, we'll talk to people within the community to try to see what's available. I'm a bit frustrated by it, in that this was a conversation that took up 2 hours yesterday of my time on a preferred option that the Trust are planning for, but actually with very little planning actually behind it. And if we're going to do transformation and planning like that, I think we're in trouble with that. So I just want to know what contact you have with the Trust around these, because the Minister says he's going to leave some of these decisions to the Trusts. And how are we going to hold the Trusts accountable for the decisions that they make and so on? I understand the objective to create sustainable, safe surgery. I understand that that's not the issue. But I'm talking about the planning assumptions that I heard, and I don't understand, and I have no understanding. I left the meeting with no understanding of how they plan to work with that, if that is their preferred option. Now, obviously, consultation closes tomorrow. They'll do what you're doing. They'll collate the responses, take them back to the board. But I didn't leave the meeting with anything other than the Trust wanted the option they wanted.
Mm-hmm. So, I mean, that's set out in the policy guidance that we issued, how that process is meant to work. So, it's a bit concerning if I haven't discussed with NIAS that that's meant to be the part of the process.
They've had numerous meetings with it, but I don't see any resolution to it. Nobody provided one to us. But I'll hand to Alan if that's all right, Chair, because he was with me.
So they will take a decision. They will engage with the SPPG, who will then engage with the PHA on this to a bit like yourself, probably ask those questions and to satisfy themselves that the proposal is sound. I'm not personally involved in that process, and not with emergency surgery, so I haven't been involved in it at all. But policy side will be engaged as well at that point. And especially if it's deemed that it's major or controversial, it will go to the minister to sign off as part of that process. So
the minister sign off the process in terms of Daisy Hill and the change in emergency surgery to Craigavon?
Secretary.
Yeah, I think we didn't have a minister at the time.
Permanent secretary at the time. Did sign that off?
I'm pretty sure, yes.
Yeah, okay. Look, again, I'm not interfering in a Alan kindly invited me because I was interested in how we arrived at, if we make a proposal for change, how we arrive at our preferred option, and in the background to make sure that our preferred option will work. I wasn't really terribly reassured, and I've just prepared a letter to that effect.
Okay.
Alan maybe wants to come in.
Diana's correct. And I will maybe be a wee bit more direct, and please forgive me, Peter, but some of the planning assumptions and some of the scenarios that were presented to us of potential patients who would be presenting themselves at Causeway Hospital were based on a world that we do not live in. They were based upon this perfect health service without the pressures that you know and we know that the health service is under. And forgive me for using this, but those scenarios that were presented to us yesterday, they were bunkum. They were total bunkum. And I was very direct in it and told them that the real world, we need to get to the real world.
Yeah. Look, I can't comment obviously on a Northern Trust consultation. All I can say is there is a process where those questions should be asked through SPPG and PHA engagement.
So just to reassure me, the department will then ask those?
That's what I'm saying.
I'm presuming.
That's what I'm saying. There's a process through which there'll be engagement with the department following this. I'm not commenting. It's not my constituency. I'm not commenting on the merits of the proposal or not. But when I looked at the planning assumptions underneath it, it caused me quite a significant bit of concern. Okay. Thank you.
Okay, thank you. So thank you both for your time today. Again, it will be good that hopefully we'll see the 3-year plan then very soon, which will detail a lot of what we've asked in relation to what the next steps are in terms of transformation. Yep. So we appreciate you both coming today. Thank you.
Thank you.
Okay, members, we have a number of written briefings then. Item number 7 is a written briefing on the mental health strategy 21 to 31, cancer strategy 2022 to 2032, 2022 to 2032, and the stroke action plan. It's at page 221 of your pack. I just would, I suppose, one quick comment really more than anything, because obviously we can probably follow up with written questions and things too, but in terms of the cancer strategy, I think last week we saw figures that are showing that cancer rates are on the increase in the north, which is deeply concerning, and I don't know whether it's worth maybe writing to the department of the minister to see if that is being factored in then to any further implementation of this, to consideration to the further implementation of the strategy and funding being allocated to that. I think for all 3 strategies, particularly mental health and cancer, when we look at the figures of what is required and what is actually being allocated, it's very worrying, given that we are seeing such a rise. And on the conference I was on this morning, we had a psychiatrist, Dr. Julie, her surname has left me, apologies, but she did a presentation, and I think it was a 30% increase in mental health patients. So when we're seeing the figures here in comparison to what's happening on the ground, Danny.
Thank you. Yeah, I couldn't agree more. Like we have the highest rates of mental health, ill health in the UK, transgenerational mental health relating to the Troubles. We have people on unacceptably long waiting lists. The percentage of the health budget that is going towards mental health in Northern Ireland is way below the rest of the UK as well, despite us having a higher need. The lists that people are waiting for treatment, they're years long. Now, the people who are on these lists are getting sicker and sicker at the time. So we have a huge problem, and I referred to in the previous presentation, I referred to the funding there. The funding requirements to deliver the mental health strategy from the funding plan are nowhere near being met. I think the first year 0.65 million was met, the second year 50% of it was met, the third year around about 20% was met, and this year I think about 14% of the required funding has been allocated. Now there's no way a strategy can be delivered without funding. I understand the financial implications of the budget, but I think there is a severe problem with mental health in Northern Ireland, and we have a huge percentage of our population that are awaiting treatment. So if we could agree to write to the Minister just about that.
Yeah, no, absolutely. Orlia?
Just to add to that, so just on the figure that you quoted there that came out of the conference today, and around the 30% increase in terms of, I don't know if that was mental illness or mental health referrals or people presenting to EDs, but I think it would be worthwhile actually putting that in writing to the Minister, and as well as I was going to raise it with him in the chamber next week, but the figures that were released last week in terms of the suicide rates, so 2023 figures are showing an 8%, possibly 9% increase on 2022, which I think is extremely worrying. I know we're still waiting on NISRA publicly releasing those figures, but I think that there would need to definitely be some urgency in terms of the Minister's response, the Department of Health's response to that, given all that Danny had already pointed out in terms of, yes, we know about the budget, we know finances are constrained, but this actually is an emergency if we're seeing that increase in people taking their own lives, given the fact that we have a suicide prevention strategy that is in place, that's meant to be active, that's meant to be operational. We need to flag that up.
Yeah. Well, thank you for that, Orly. I think that actually is a critical point as well. Okay, so if we can write on that, and I suppose we can follow up ourselves as well on anything more specific in relation to that. Are you content then to note those briefings at this stage? Okay, the item number 8 then is a written briefing on the implementation of the Community Pharmacy Strategic Plan 2030. The committee will be receiving an oral briefings from Community Pharmacy NI and the department on the 6th of March on the strategic plan, particularly as one of our committee priorities is community pharmacy. Orlia, do you want to come?
Just very quickly, so on the issue of the community pharmacy, I know there was an announcement this week around the services that they're rolling out for sore throats, the pharmacy first, which is brilliant. It's obviously kids from 5 years plus can get assessed and can receive their treatment in the pharmacies, but I think that the fact that the service is only in place over December and January, it's only for 2 months, and I don't, with members' agreement, I don't know if you would agree with writing to the Minister to maybe suggest that when you have good initiatives like that, that's taking the pressure off GP appointments, why we only have it in place for the 2 months of the year. Maybe if it's something that could be considered that it's rolled out, all year round in terms of the community pharmacy, I think that would give some more stabilisation to the pharmacies that's rolling out the scheme, but also then in terms of the public being clear in terms of, if you have a sore throat, you can go directly to your community pharmacy rather than it just being the 2 months of the year. But I think it's a brilliant initiative. It's maybe just to see if we could request that it's extended all year round.
Yeah, I think that is a good point, because 2 months, by the time people even know it's in existence, it'll probably be finished. And it is based on the success of the pilot project. So there's a good evidence base there to show how well it works. So I think, we should do that. Diane?
I may have missed this, so forgive me. We did write, didn't we, to the department to try to get their assessment of the increases on national insurance contributions and so on pharmacies, dental practices and GPs.
Yeah.
We did do that. And we haven't got anything back yet. No.
Right, Chair.
Yeah, sorry, Danny.
No, you're grand. I understand this strategy is subject to additional recurrent funding and a new IT system. What level of funding is required? Do we know?
No, but we can ask.
Yeah, thank you.
Yeah, no, thank you for that. Okay, members, anything else on that one? Happy to note for now. I think there'll be more. I mean, many of us are probably in regular engagement with community pharmacy NI, so there is lots of issues that remain unresolved. So
I just at one point as well.
Yeah.
We know, and what Orlia has referred to there is the scheme about sore throats over the winter. I do think when we're hearing again and again there's a crisis in community pharmacy, that part of the winter protections is then going to involve community pharmacy. I do think it's lumping more pressure on them at this time. Can we get a response from the Minister just about what he's doing to support community pharmacy at this time?
yeah, no, and I think I'd actually had this discussion with someone, I think last week, on the winter preparedness. So everything was directing people to community pharmacy, but we're not seeing really that what level of funding or support. So I'm happy to do that as well. Thank you, Dan. Okay, members, so item number 9 we have already covered. Item number 10 is correspondence. If I could refer you to the correspondence list at page 259, and your correspondence then, the individual items start at page 260. Has anyone anything specific to raise on that one? Or are we happy to note are we happy with the suggested actions for the remaining items? Yep. Okay, thank you. Item number 11 is the forward work programme. The draft forward work programme is in your meeting packet, page 318. We have an informal session on Tuesday the 3rd of December, this Tuesday coming, in room 21 at 1 p.m. And that's with the Patient Client Council, and we'll also have Charles Little in attendance and other families who have lived experience in terms of the SAI process and that redesign of the framework. So hopefully if anyone is planning to attend or can't attend, to let Jonathan or Keith know.
What date's that, sorry, Chair?
Tuesday the 3rd of December, this Tuesday coming. We also then, as part of our work for the palliative care inquiry, we have a committee visit to the Northern Ireland Hospice and the Children's Hospice next Thursday morning, the 5th of December. As I said, this is the first of a series of visits as part of our inquiry work, and the committee meeting will go ahead that day, but a later starting time of 2:30. And then from detail will be sent out if it has already been. Yeah, we should have that anyway. Just if anyone hasn't confirmed whether they can go or not, to please do so as soon as possible. And we have an effective questioning session scheduled for Thursday the 6th of February 2025 as well, with details to follow. Are members then content to note the briefings as set out in the forward work programme?
I see just on Tuesday's informal session, sorry I must have missed that in my emails, but with the families around the SAI process, there was a girl, Joan, that had been in contact with us in writing. Was she notified?
No, this here session is with the PCC have a...
Oh, that actual PCC group?
Yes, so it is.
Okay.
So we're aware of the other one.
Because there's a group of... She's part of a group of different families from across the north who have, but I don't think they're tied into any structures. No. That's okay. No,
this session on Tuesdays with the PCC group that are being formally engaged by the department on on the SAI framework.
So we're still going to make time for those other families as well. No, that's grand. Thank you.
Okay.
Thanks.
Okay, members, content then with the briefings? Yeah, is that right? Okay. Any other business? No. So, as said earlier, our next meeting is next Thursday, 5th of December at 2:30 p.m. in room 29. So, thank you all.
Committee room 29. Sound. Committee room 29. Sound. Committee Room 29, 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 sound.